Thank you for joining us. This is The Economy. I'm your host, Ibrahim Sani. 2026 is also quite a year for Malaysia as we are grappling with the silver economy status. We're also trying to understand a little bit better in terms of how we're managing the reproductive rate. That stands at 2.1 right now, barely making it in terms of trying to break through growing the population, and of course trying to see how the healthcare sector is going to impact the economy. Here to discuss this and more is the renowned professor, Dr. Murallitharan M, or Dr. Murali, as we all know him. The last time I spoke to him was roughly about 4 or 5 years ago, so it's a good time to catch up on things. Dr. Murali, very recently you wrote on a very interesting piece in the Edge, where you talk about the economics of healthcare. And how healthcare and health is impacting the economy. Maybe you would like to walk through with us in terms of what was the genesis or the philosophy behind you coming up with that op-ed on how healthcare is impacting the economy and vice versa.
Lovely. So first of all, thank you so much for having me. It's always a pleasure and an honor to be on anything with you, really. I think what the problem is, I think, for two disconnects that I think we keep on facing in terms of with stakeholders, with policymakers, and that. A lot of people think that health is a cost. It's either you go at two ends of the spectrum. They either see healthcare as a cost, it's an expenditure. No one thinks about healthcare as an investment, and that's a case to be made for that as well. But there's also a very interesting perspective now that healthcare is also a big revenue generator. It's also a kind of money earner for individuals, for the country, and that's where there's kind of a disconnect, if you will, between these two very different perspectives of looking at health. But also on an individual level, health impacts us in different ways economically. So with good health, you're able to generate a lot more income. But you also spend quite a bit of your income on health as well. So it's something which is very correlated, I think very entangled, but people don't kind of understand or actually work towards balancing these things out.
But of course, you look at developed countries, very highly developed countries, you're looking at paternity leave being a mandatory 1 year. Maternity can go up to 2 years, and that's the reason for this, especially when it comes to what do you call this, breastfed babies that have a lifelong impact. For instance, you can see health results, healthcare of the individual reducing risk significantly if it's being breastfed for up to 2 years. So this kind of thinking is also quite important, because it's not a loss on the productivity of the nation when a person, say a mother, takes off for, let's say, 1 year or up to 2 years. It's actually going to save the country
a significant amount.
Absolutely. Economic savings, because then the public healthcare system is reduced, lifelong care is going to be reduced, and you're going to have a much more productive people, a citizen running into the 65 age or 70-year-old age. These are all fantastic lifelong learnings, and we know about this. I'm surprised that we don't apply it here in this country.
Absolutely. I think as you say, sir, the thing is, people allude to this, they think about it, but no one is kind of incorporating it into how we're actually exercising our kind of fiscal thought processes at all.
Yeah.
So things like, for example, I can even tell you, breastfeeding a child even reduces the risk for the mother to pick up cancer.
Yeah.
So that's another.
So it works both ways.
Absolutely. So there's just a lot of interplays. But in our world, we consider that, hey, kau dah 3 bulan not coming to work. It's like, and unfortunately, and this is a sad reality, women on long maternity leaves, or even those who are taking out time from the workforce to take care of their kids, they actually face an imbalance. Their careers never go back to normal. So I
refuse to believe that our current health minister, Dr. Zul, is unaware of this. I'm pretty sure he is. And I'm pretty sure a lot of our friends over at KKM is also thinking about it. And we have a lot of medically qualified MPs right now being voted into the office of the Dewan Rakyat. What is stopping us from changing our healthcare policy to reflect the upside on the economics of things when it comes to healthcare and having good lifelong healthcare with economic policies?
So, ironically enough, almost all of economic policy lies outside healthcare, and that's the major disconnect. Healthcare, actually, in this country, the way it's being viewed now, is really sick care. The Ministry of Health should be called the Ministry of Illness, because everything that they govern is around illness. When you're healthy, actually, the Ministry of Health has nothing to do with you. In fact, we have very, very little kind of interaction with those who are healthy within the healthcare landscape. But everything to do with keeping you healthy lies outside that. It's with every other ministry, if you will. It's with your workplace, it's with your residential kind of area. So it's within those pockets that we actually have no interaction. And I would say we have a poorer kind of acceptance of healthcare within this ecosystem. So, but once you're sick, off you go. But before that, there's all these different things that you do which impact your healthcare and impact your economic kind of output or your depreciative value, if you will. But these lies outside healthcare. For example, we had a very interesting discussion when the government first came up with this My 50. Remember this idea of I'm paying for you to get public transport. So sure, it's a subsidy, but interestingly, if you compare head to head, us versus Malaysia, Kuala Lumpur especially, versus any other metropolitan city in the world, our commuters just walk a lot less.
Yeah.
So we struggle.
There's a study on that I just read.
Yeah, absolutely. We struggle to reach 10,000 steps or whatever. If we could, Malaysians would drive into the toilet bowl.
Yeah.
Dia nak pergi tandas. But see, every other urban city, because you prioritize and you incentivize, that's an economic incentive of public transport, you get an inordinate optimum, like kind of positive gain on health by making people use public transport. But it's a dividend that we don't see or we don't capitalize on.
But still, these are well-founded research.
Yeah, absolutely.
Folks like you and me can talk about this until the cows come home. But yeah, what's stopping us from exemplifying that so-called sick ministry to health ministry?
Yeah.
Because I'm sure there is a national policy here that we're not seeing.
Absolutely, and I think one of the kind of takeaways from today's discussion, I think, should be exactly that. Is there a policy overarching kind of cohesively tying kind of health into all policies? By the way, the WHO looks at this very seriously, meaning they have this stand on health in all policies, but how much is it being translated across government? That's I think a good question to
One item that I saw that is quite interesting in the op-ed that you wrote was the impacts of economics on health, and then later on you wrote the impacts of health on economics, and that interplay is sometimes quite forgotten. What would be the 2 or 3 things that you think we should know of when it comes to health and economics that we must really think about? That just now that you're mentioning, when you're healthy, you got nothing to do with the health ministry. That's perhaps one of the bigger things that I can take away from this conversation. But the 2 or 3 other things that you want to share?
Absolutely. So let me take a workplace perspective. I think this is the kind of, we spend 10 hours at work every day. It's the biggest environment in which a functioning, productive Malaysian is in. So we cover health insurance for our colleagues at work, which essentially does not kick in until they are ill. So we're paying for risk protection, but there's no real health gain per se. Okay. However, in a similar setting, employees or employers actually will balk from, for example, putting up a gym membership, or even, for example, incentivizing their colleagues at work to go and get a health preventive screening. We don't pay for checkups, by the way. People pay out of pocket. So something along that line.
Unless you're C-suite or something like that.
Yeah, absolutely. And even then, it's offered as like by the by kind of.
Yeah.
So essentially, even things as simple as that go a long way towards kind of driving the health kind of perspective of a saving that you'd actually get.
And the bizarre part, I'm sorry, I'm already thinking numbers now.
Yeah.
Because what is the cost of a gym membership or health screening as opposed to chronic illness disease care?
Absolutely.
I'm telling you, it's a fraction. I'm telling you.
Absolutely. And it's so much of a saving that it doesn't even make sense that we don't think about it.
But we don't think about it.
Yeah, exactly. So at best, and this is even worse. For example, you get Social Security per queso. Per queso offers you health screenings for free at the workplace.
Yeah.
But no one even thinks of kind of even pushing in a program or, for example, making sure that, hey, I would make sure that your KPI this year includes for you to get a health screening, which is already being paid for at the very minimum. Try to get that sorted out. So it's things like this. We have a lot of programs in different ministries, for example, that could fund some of these things. I mean, screening is not an end-all thing. It's just one of those little things pertaining to health. But even those little things, we can't optimize.
Okay, that's one idea.
Yeah.
Another idea?
Okay. And now, on a personal level, we always talk about food. Food essentially is what makes all of us, the world go round, especially in Malaysia. But we speak about healthy eating, okay? But healthy eating is not cheap, not in this country. So, and again, there's a lot of skewed kind of perspective that healthy eating is kale. It's what is this? Some bean which is grown on a volcano somewhere at the end of the ocean, but it's not these things at all. It's regular produce, fruits, vegetables, even meat, which is obtained or grown in a healthy environment. And making sure that you get enough amounts of that is something which is almost impossible to do if you are an average, like say even I forget about B40 sir. M40 cannot eat healthy in this country. It's almost impossible. None of our meals are tailored to it. For example, if you walked around even our workplace today, if you wanted a so-called healthy meal, you're talking upwards of 30 ringgit. So what does everyone do? You resort to low value, high fat, high kind of caloric choices. This is something we should be incentivizing again, but this is an area that no one even looks at.
Yeah, because roti canai with dal is what, 3-4 ringgit.
Yeah, absolutely.
A salad or a Greek yogurt with salad is easily 25. Easily.
Yeah, exactly. But why can't a policy like drive something like you don't have Greek yogurt with salad, raita with Kobe juga sebenarnya. But yeah, exactly.
Yeah.
Exactly. So it's these kind of things that no one's kind of pushing the envelope on.
Unless you take your own personal awareness seriously lah.
Absolutely.
But this is a time that we need to talk about all these items: our workplace, incentivizing healthcare, lifestyle, eating healthy. Also, I think if we haven't gotten the memo yet, we need to actually look at this. Malaysia has the highest non-communicable diseases per ratio, rivaling our friends in India and Sweden for some reason. I don't know why.
I think we've beaten them flat though, but you know.
Oh, really?
Malaysia
my data must be 5 years dated now.
Yeah.
That's one item where NCD is a growing concern. And then cardiovascular illnesses, that's the number one killer in Malaysia.
Yeah, absolutely.
Number two being road deaths.
Road deaths lah.
So,
and the problem with cardiovascular deaths is, this is a horrible thing to say, but I'll say it. It would be so much cheaper if they died.
yeah.
Unfortunately, I'm speaking like.
You're a physician.
Yeah, from an economic perspective, it's when they don't die that their families themselves, everybody else has to suffer through the cost of caring for them as well.
Are you kidding me? My God, these are all like.
This is a horrible statement to make, but
it's
the
true.
truth. Exactly.
It is true, because the care element. I mean, prior to this conversation, I just spoke to the doctor just now. My sister is a consultant rehab physician, and she was telling me the cost of caring for a family member that is chronically ill. It's just insurmountable, and there's only so much that the Ministry of Welfare, Ministry of Health can cover. Basically, if you're in your T20, it's already troublesome. or a nuisance in terms of the expense, it is debilitating for an M40, let alone crippling for a B40.
Yeah. So, and then I don't know whether things like, for example, you saw this thing about 1 or 2 weeks ago that there was a little outcry about, finally people have started speaking out about, during holidays, this is a phenomenon that happens all across Malaysia. During holidays, people dump their old folks into government hospitals.
I didn't.
So they'll show up to...
So wait, you got to rewind this. What was it?
So during holidays, okay, what happens is, Malaysians, all walks of life, cuti.
Enjoy.
So cuti, my elderly parents or something that or the ill person I'm caring for at home gets dumped in a kecemasan and then left to be admitted for a couple of days because I got to take a breather. So again, I mean, forget the morality of it and all that. It's a huge problem. But talk about the economics of it. Just that additional load onto public sector healthcare. So it's crazy at a time when during holiday seasons, as you know, that's the time when staffing is low.
Yes.
So you overload overtime, you overload extra working capacity. All this is contributory.
So we shouldn't be, from a national perspective or national policy perspective, we shouldn't be looking at the development expense on the health ministry or the OPEX on the health ministry. We should be looking at other areas like Community of Women, Family Development, Ministry of Youth and Sports, Ministry of Economy, because these are the areas that will reduce the load on the health ministry.
Of Health. Absolutely. So what people don't realize is one of the biggest things that contributed to people starting to live longer was clean water and sanitation. Yeah, in the 1900s, it changed the entire kind of landscape of Europe. Clean pipes, nothing to do with the Ministry of Health. Clean drains, nothing to do with the Ministry of Health. And buildings in which people didn't die at night.
Because they put asbestos and lead and everything.
Absolutely, and people started living into their 60s
what I call
and
this,
70s.
Soot from open fire inside houses.
Yeah. None of this, Ministry of Health. And similarly now today, for example, we talk about road, just take the two biggest causes of death, sir. We're talking about road traffic accidents, nothing to do with the Ministry of Health. Yet, that's how much of cost is coming to the Ministry of Health from all these other...
the trauma injury.
Yeah, absolutely. And let's look at cardiovascular disease. Largely, again, still a disease of lifestyle.
It's lifestyle. I mean, yes, of course, as a doctor you will tell me, genetics does play a part. But it's still lifestyle. You can still mitigate the risks.
Absolutely. And I make a case that all these can be done by economic measures in no small part.
Oh, wow. Okay. Thanks for painting a bleak picture here. But I'm sure there are some optimism left in you, Doctor.
No, for sure. There's a lot.
So what would be the 3 or 4 things that you want to share with us in terms of how do we address this?
Absolutely. So one is, like I said, on an individual level, or your kind of nuclear unit, your family level, there are a lot of good decisions that you can make which will yield economic results as well as health results. So and these are things which I think are really beneficial. For example, people talk about, I don't have a garden. There's a reason why people living in rural areas in Malaysia live longer, healthier, happier lives. Even though they're not as economically well off as those living in the cities. It's an absolute kind of showpiece. For example, things like, is it possible to kind of set up a little corner of even your flat to have to grow your own kind of micronutrients? Why not? Microgreens. Not too difficult a task. But interestingly, returns a lot of quality of life. Returns quite a bit in terms of reducing mental kind of health factors. Interestingly, giving you quite a return on your economics as well. Imagine the food bills that start to go away from you not having to buy kale.
Contextualizing it to local produce. We're not talking about rosemary and thyme. We're talking about chili, daun kari, daun kesum.
Absolutely.
There's nothing wrong with growing these kind of items.
And interestingly, what people don't realize is 3 servings of fruit, 2 servings of vegetables, 5 servings, which is essentially only about 4 tablespoons per serving, reduces your cancer risk by about 18-20%.
Yeah, of course, because high fiber diet, high protein, high vitamin diet, colon cancer reduction, for instance. Okay, what else?
Yeah, so this is on an individual level, for example. On a community level, things like, for example, at workplaces or even within communities, we have lost, for example, this whole communal kind of. Humans are communal animals. We are creatures who need to be in packs, and a lot of communal activities. Again, I point to countries like Thailand, like China. We used to have a good culture of getting together and exercising, for example, in communities. This has disappeared entirely. Again, almost no costs attached to it. You get a really expensive gym membership, which you go to twice a year, and you rarely have any time for. But in countries, again, I point to countries like Thailand, China, within workplaces, already after work, you got hundreds of people getting together. Interestingly, restoring mental health, physical health at almost this huge economics gain without any kind of economic costs attached to it.
But I do see some pocho crowd, right? Where
but again, if you notice, outside the city. Outside the city. In smaller towns, I can see this happening in like Kuala Kangsar, Tapa and all that. Okay, kita atas, bro. It's too... Yeah, so things
but
like
it's not just. Of course, it's the cardio part and the community part, but it's the mental health.
Absolutely, I cannot understate it.
If anything, arrest the mental health decay, and the growing concern of loneliness in an urban setting. Yeah. And from a national perspective, a national policy perspective?
Okay, from a national policy perspective, I think the biggest thing to look at is everybody outside the health sector needs to start looking at, within my sector, what can I do to actually give national health returns? There are many things that many ministries or sectors can do, which will ultimately, I argue, they'll even give them their own sector and economic kind of gain as well, but also have this huge multiplier effect on health.
Do you think that Malaysia is, I guess, optimistic or heading in the right direction in terms of looking at this, or do you think that we are completely unaware of this and we got everything backwards?
So I think we have started looking in the correct direction, but our direction, in the sense that as a nation, you can start to see that people have this kind of a bigger tendency or propensity to kind of look at their health. For example, about 8-9 years ago, if you went to Lake Gardens in the morning, it'd be dead. Now, even on a weekday, it's full.
Yeah.
People are starting to kind of look at their health, move a bit more. So, but what's not there?
It's a new flex, right?
Yeah, absolutely. It's a new flex. People are eating less, they're eating healthier. I hope they're eating healthier. God knows it's expensive though. So things like this are starting to happen. But is it making enough of an impact? Question mark. But for sure what we're lacking is institutional kind of cohesion around policies which are health promotive, but also economically incentivizing.
But I guess I can agree with you. We are heading in the right direction. It's just how fast are we going?
How fast are we running? Are we running fast enough to beat the cardiovascular, the heart attack that's creeping on?
No, you know this for a fact. No, I mean,
absolutely.
especially if you're a male and you have comorbidities. I don't think.
Absolutely.
I don't think we're gonna last long. What about cancer growth in Malaysia? No pun intended. But the people with suffering from cancer, being the head of NCSM, do you think that the cases are getting more severe and frequency and recency and prevalence is also increasing?
Prevalence is increasing. We're seeing a lot more cancer.
Wow.
That's for sure. But this is not a Malaysian phenomenon, globally as well. There's just a lot more cancer. Our problem, which remains very significant, is we still about 70% of our cancers are being picked up in late stages.
Yeah,
That
because
is,
of your earlier
Yeah.
statement just now,
Absolutely.
the health screening part
Yeah.
was...
that is a huge system failure. We're trying our best to start fixing it. It's a long process.
Okay, that's one.
Yeah.
But in terms of prevalence, but in terms of incidences?
It's, absolute numbers
Yeah.
are creeping up, that's for sure. But in terms of the population, it's also a population that's living much longer as well.
Yeah.
Compared to like 10 years ago.
Yeah.
10 years ago, I mean, and this is the good news and the bad news, I suppose. 10 years ago, all my teachers died of heart attacks.
Yeah.
They were dead by the time we finished university.
Yeah.
You know, now they're all still alive, but they're picking up cancer.
Yeah.
You know, so it's a demographic shift as well.
Yeah.
But also, again, the problem is, and again, this is the economic cost. Because we're picking it up so late, we're spending about
So
up
much,
to about 10 times more
Yeah.
trying to treat the same people.
Yeah, when earlier prevention could have actually managed the cost lower.
Yep, 10 times cheaper.
Yeah, and then chemotherapy can be done earlier. And perhaps even at least warning signs are there, so you can even prevent it altogether.
Yep, absolutely.
Is it a stigma issue?
Yes, but also an economics issue. Because it comes back to I have to pay. The way things are nowadays, our insurance doesn't really pay for you to get screening. So it's something you have to pay out of pocket. But do I, for example, at the end of the year, prioritize my kids punya baju sekolah?
Yeah.
Or, so it becomes a kind of a pick and choose thing. It shouldn't be.
Yeah.
But also, perhaps the take home is pay a little more attention to making that choice.
Yeah.
A little better rather than picking up the new phone that's from that fruit.
Right.
Yeah.
Right.
So we make choices which are expensive but not necessarily correct. That's
And
the other
I think if we get a lot more political actors coming in and understanding this issue better, then they can perhaps design a policy program or national policy that is a little bit more facilitative in this grand design.
Yeah, absolutely.
But you think it's a long way, or you think that this is a...
I think if we started, like I was talking to you about this, the My 50, that's an interesting kind of policy which was rolled out actually to save money, but has very interesting unintended positive effects. I'm hoping people can do stuff in mind having intentional positive effects for health.
And if people want to learn more about this, do they go to the National Cancer Society Malaysia's website or any other resources that they want to learn more?
I mean, there's a lot of people talking about economics and health. I think I shouldn't plug.
Yeah.
But a lot more of my work on the edges is exactly going to be around this.
No, you should plug.
Yeah.
I mean, people want, you're supposed to do advocacy as well, but yeah.
No,
that op-ed in the Edge is actually quite a very interesting piece to read. Thank you very much. That was Professor Dr. Murallitharan M, the Executive Director of the National Cancer Society Malaysia. If you want to learn more about this or the kind of shows like this, just head on to AstroAwani.com and find out more there. Also, do read up on Professor Dr. Murali's work as well. That's quite an interesting piece that you can get from Bibs and Bobs here. And also drive up the subscription numbers of the Edge. We're helping out a fellow journalist here as well. Thank you very much for joining us. Catch you in the next one. Thank you, Dr. Murali.
Thank you, sir.
Thank you.